Okay, good morning. So, in this lecture and the coming three lectures, they are like overviews. We have spent three lectures on the thorax. So, we'll have an overview of the abdomen, and then next time, overview of the pelvis and perineum, and then overview of the upper limb and overview of the lower limb. So, you don't expect much details in this lecture or even in the practical, and you are not required to know, for exam purposes, anything outside the PowerPoint presentation of this lecture and the lab manual. But it's up to you if you want to go into details to study something that might be, probably you find it helpful for your physiology or for some or for your histology or whatever. It's up to you, but you are not required to, for exam purposes, to go beyond this lecture. So we will start with the abdominal cavity. So the cavity of the abdomen. You know that in the body there are two cavities. They call it anterior body cavity and posterior body cavity. I don't want to go into details, but the anterior body cavity contains the thorax, thoracic cavity, and the abdominopelvic cavity. So the abdominopelvic cavity is separated from the thoracic cavity by the diaphragm, which is, we can call it the thoraco-abdominal diaphragm, and you have studied the diaphragm. But the abdominal cavity is continuous with the pelvic cavity, and the border between them is just an imaginary line at the pelvic brim, which we are going to study that later on. So the abdominal cavity and the pelvic cavity are continuous with each other. There is no diaphragm separating between them, and there is an entity which is called pelvic diaphragm. This is located at the floor of the pelvis. We are going to study it next time. So the pelvic diaphragm separates the pelvic cavity from the region which is called perineum. It does not separate the pelvis from the abdomen. There is no separation between them. As far as the bones are concerned, we have the 5 lumbar vertebrae and their intervertebral discs. We have the lower part of the thoracic cage. Remember that the diaphragm is dome-shaped, so that's why upper abdominal viscera are enclosed by the ribs and their costal cartilages. And there are also the upper part of the hip bones are also included in the bones that are present in the abdominal wall. However, the abdominal wall is mainly formed of muscles. So we have some muscles in the posterior abdominal wall, and we have others in the anterolateral abdominal wall. Of the muscles that are present in the anterolateral abdominal wall, we have 3 layers, and these muscles are more or less similar to the intercostal muscles. The difference here is that there are no ribs intervening. They are continuous sheet of muscles. So we have, for example, here, there's the external oblique muscle. It's oblique because the fibers are oblique. They have the same obliquity of the external intercostal muscle fibers, downwards and forwards. And then we have the other one, which is the internal oblique muscle, deeper to it, and have the same obliquity of the internal intercostal muscle, downwards and backwards. And then the deepest of all, the 3rd layer, is called the transversus abdominis muscle and has horizontally arranged fibers. So 3 layers of these muscles, and then there is a muscle on either side of the midline, which is called the rectus abdominis. Rectus means straight. So it's a straight muscle of the abdomen, and this muscle is characterized, different from other muscles, in that it has what we call tendinous intersections. There's fibrous tissue, tendons, in between the muscle fibers. So there are tendinous intersections, and this gives the appearance in muscular people of the 6-pack abdomen, the presence of tendinous intersections in the rectus abdominis muscles. The function of these muscles is that they support the abdominal contents, and most important is that they increase intra-abdominal pressure. This increase is required for many purposes. It's, for example, is required for a forceful expiration. It is required for micturition, defecation, childbirth. So it increases intra-abdominal pressure by their contraction, and also it moves the trunk. Surface anatomy of the abdomen is important, and these are 2 ways of how to approach the surface anatomy of the abdomen. So either we divide the abdomen into 4 quadrants, and this is very easy, using a plane that passes through the umbilicus, horizontal plane, and a vertical plane in the midline. So we have right upper, left upper quadrant, because 4 quadrants, right lower and left lower quadrant. To be more specific, and this is more likely used in clinical life, is to divide the abdomen into 9 regions. And we are going to do that in the practical. I'm not going to go into details of that. You can use your lab manual and follow how to divide the abdomen into 9 regions. But just to give you an idea that in order to divide the abdomen into 9 regions instead of 4, you need 2 vertical lines, and these are midclavicular lines. You are familiar with the midclavicular line from your study of the thorax. So 2 midclavicular lines, and then you need 2 horizontal planes. One of them is called either it's called the subcostal plane below the ribs, or sometimes they use what's called the transpyloric plane. And the other one is located here, which is this one, the dotted one, which is called the intertubercular plane. So we have 9 regions. It's called the right hypochondrium, epigastrium, left hypochondrium, and then right lumbar, umbilical, left lumbar, right inguinal, suprapubic, and left inguinal region. 9 regions. So these are used for descriptive purposes. So for example, you say when you communicate in a professional way that the patient presented with pain in the right hypochondrium. And when I examined the patient, there was a lump in the epigastrium. And then the pain shifted into the umbilical region, and so on. Okay? So these are used for descriptive purposes. And of course, you need to know, like in your mind's eye, what is there deep in these regions. Let's say, for example, here in the right hypochondrium, it's mostly occupied by the liver. In the right inguinal region, there's the appendix, for example, and so on. Now, inside the abdominal cavity, we have another, the cavity, which is called the peritoneal cavity. And this is the same story as the pleural cavity and the pericardial cavity. Again, there's a serous membrane, which is called the peritoneum, and this is a continuous membrane. When it lines the walls, it's called parietal. When it covers the viscera, it is called the visceral peritoneum. And in between these two is a very thin layer of serous fluid, and obviously this reduces friction, because inside the abdomen, if it is the gastrointestinal tract, then we always have peristalsis, so there is movement. Gastrointestinal organs, they distend with content, so they need something to reduce friction in between the organs. The only difference here is that some of these organs is only covered by peritoneum anteriorly and laterally. It's not covered posteriorly. So these are called retroperitoneal. Some other organs, especially in the gastrointestinal tract, small intestine, for example, they are almost completely covered by peritoneum, and they are suspended by a double fold of peritoneum, which is called mesentery. So they are called intraperitoneal. The term might be confusing, intraperitoneal. They are not inside, but they are almost completely covered by peritoneum, as you can see it here. So when we describe abdominal organs, we say that they are intraperitoneal or retroperitoneal. Again, the term intraperitoneal is confusing. It doesn't mean that it's inside, but it means that it has a double fold of peritoneum, which is called mesentery. Inside the abdomen, we have organs that belong to many systems, mainly gastrointestinal, but we also have the spleen, which belongs to the immune system. We have the kidney, the ureter, which belong to the urinary system, and the suprarenal glands, which belong to the endocrine system. We'll start with the gastrointestinal organs. So we have a small piece here of the esophagus that passes through the diaphragm. It's about 2 centimeter length of the esophagus, which is called the abdominal esophagus. And this opens into the stomach, distended part. The opening is at what we call the cardiac orifice of the stomach. It's called cardiac because it's so close to the heart above the diaphragm. So that's why it's called the cardiac orifice, or they just call it gastroesophageal junction, if you would like to call it. And then we have the upper part of the stomach here, dome-shaped, the highest part above the gastroesophageal orifice is called the fundus of the stomach. And if you are standing and you're taking an X-ray, gas will usually go up into the fundus of the stomach, just below the diaphragm. So when you find gas in the stomach, it's actually in the fundus of the stomach when taken in the erect posture. The stomach has a body, most of the stomach, and then a pyloric region, which ends up into a narrow part, which is called the pyloric sphincter. And you can see it here. Sphincter means that there is thickening of circular muscle fibers, smooth circular muscle fibers. So they form a sphincter. And here, this is called the pyloric sphincter. This controls the passage of contents from the stomach to the duodenum. And it has two curvatures. One is small, so it's called lesser curvature, and the other is big, and it's called the greater curvature of the stomach. Inside the stomach, there's a very characteristic pattern of mucosal folds. Okay? So these mucosal folds, of course, they help the stomach to distend, but the characteristic thing about them is that they are longitudinal, and they are called rugae. They're only present in the stomach. If you compare the folds here, which are present in the duodenum, you will find that they are circular, horizontal folds, unlike these, which are called rugae. So rugae are mucosal folds which are located inside the stomach, and they are a characteristic feature of the stomach. If you are looking at the inside of the gastrointestinal tract with an endoscope, then once you see the rugae, then you are in the stomach. And the stomach is connected by a double fold of peritoneum from the lesser curvature to the liver. So it's called the lesser omentum because it's attached to the lesser curvature. And there is another one which is called the greater omentum, and it's attached to the greater curvature of the stomach. You can see it here. And this greater omentum, it hangs down from the greater curvature in front of the small intestine, and then a double fold returns back to the transverse colon. So it's like an apron, and when the abdominal cavity is opened, the immediate thing that you see in front of you is the greater omentum. It contains blood vessels, lymphatics, and a lot of fat. As you can see here, the amount of fat depends on the nutritional status of the individual. So we have a greater omentum and the lesser omentum. Sometimes the greater omentum is called the policeman of the abdomen, and you will see why it's called policeman of the abdomen when you watch one of the videos that we will have in the lab. The small intestine is a narrow tube. It's about 6 meters in length, consists of 3 parts. The duodenum, which is the first part, is a C-shaped, and then we have the jejunum, and then the longer is the ileum, which ends into the large intestine, into the cecum. And the inside, as you can see here, the inside of the small intestine is thrown into circular folds. Remember, these are not rugae. These are circular folds. And the presence of these folds, of course, the small intestine is mainly for absorption. So these folds, they will increase the surface area for absorption, in addition to other structural features, which probably are going to study in the histology. You can only see by the microscope, like the villi and the microvilli. This is the duodenum. It is a C-shaped structure. Most of it is retroperitoneum. And so it starts from the gastroduodenal junction and to the duodenojejunal junction. Probably the names are long, but they indicate the beginning and the connection between 2 parts. It's 12 finger breadths in length. That's why it's called the duodenum. Duodenum means 12. These are the parts. We have the first part of the duodenum, second, third, and fourth. The first part, as you can see it here, looks like a cap. So it's called the duodenal cap. Why we are interested about it? Because this is the part that is most likely affected by a peptic ulcer. It is the first part after the stomach. So gastric contents are more or like acidic here when they come. And so this is most likely affected by peptic ulcer. The second part has an important feature here, which is called the major duodenal papilla. This opening here is like a prominent part in the mucosa. It's called major duodenal papilla, and it is a common opening of two ducts, a bile duct and pancreatic duct. They open into the major duodenal papilla. The large intestine has these parts. It has the cecum with the appendix, then ascending and a colon, and then transverse, and then descending, and then sigmoid. Sigmoid means S-shaped, so sigmoid, colon, and then the rectum, which means straight, and continues as the anal canal. The characteristic feature of the large intestine is that it has teeny coli, what we call, these are arrangement of the longitudinal muscle fibers, like this one. I'm following it here. I'm following it here. So these are called the teeny coli. Have you studied the histology of the gastrointestinal tract? No. Okay. So it's a tube. Inside the tube, there's a mucosa, and then there is a submucosa, and then there's a muscular layer. The muscular layer is in two parts. So there are circular muscle fibers, smooth muscle fibers, and then there are longitudinal muscle fibers. So if you cut a section, then you can see the circular muscle fibers if you cut a horizontal section, but the longitudinal muscle fibers will be in front of you. So you find them as, like, let's say, as dots like that. And they are all around the tube. That is true for the stomach, for the entire small intestine. But when it comes to the large intestine, and in specific the colon part of the large intestine, these longitudinal muscle fibers will arrange themselves into three bands. So we'll have band here, a band here, and a band there. Three bands, which are called teeny coli. They are not present all around the circumference of the tube. And so that's why the tension in these teeny coli, the tone in the teeny coli, will make them shorter than the rest of the tube. And that's why we will find that, as you can see it here, the wall of the large intestine will become sacculated. It's the same idea like the elastic waistband in a short. So the elastic waistband make the upper part of the short, make it crumpled like that. So you will have these what we call sacculations, which are called hostra. So there are the teeny coli, you can see them by your naked eye, and you will see the hostra from the outside as well as from the inside if you are doing a colonoscopy. So these are features that are not present in the small intestine. In addition to that, there are finger-like projections attached to the large intestine containing fats, and the size and the amount of these, what we call omental appendices, depends on the nutritional status of the individual. So these are the three main features that differentiate large from small intestine. Yeah.
What's the significance of the colon bunching up like that?
The significance is that there is mixing, there is more absorption of water, because mainly the main function of the large intestine is absorption of water. So the contents will take longer time to move from one place to another.
Like 2 sections at a time, stretching up and all, like stretch and then contract.
They should stretch and contract like any other smooth muscle fiber, but the stretching and their stretching and contraction will not affect the tone that they already have, which makes the sacculation. So they stretch and relax within a limit. Okay? The first part is the cecum. It's a distended part, and opening into it is the appendix, or vermiform appendix, because it looks like a worm. This is a narrow part, about sometimes 10 centimeters in length, and it has a lot of lymphoid tissue in its wall. And because it's narrow, because it has a lot of lymphoid tissue, so when it's inflamed or when it is blocked by a piece of content, then it will become inflamed, easily inflamed, and that's why this results in appendicitis. And there's the opening of the ileocecal orifice here. And then after the cecum, we have the ascending colon, which is present in the right lumbar region. As it reaches the visceral surface of the liver, it will bend, and it will flex in a flexure, we call it. So it's called the hepatic flexure or the right colic flexure, and form the transverse colon. And this, as it reaches the spleen, on the left side, it bends to form the descending colon. The ascending colon, descending colon, they are retroperitoneal, remember, and the transverse colon is intraperitoneal. So it has mesentery called transverse mesocolon. And that's why you can move it in the cadaver. It can be moved. It can be reflected up because it is suspended by a mesentery, while the ascending colon and descending colon, they are plastered to the posterior abdominal wall and they cannot be moved. Of course, that is in a freshly dissected cadaver. Probably you will not find this in the cadavers that we have in the lab because we have dissected all of this out, but in a freshly dissected cadaver or during a surgical operation, this is what happens, that you can move the transverse colon, but you cannot move the ascending and descending colons. And also you can move the sigmoid colon, which is the continuation of the descending, so it becomes intraperitoneal here. It has a mesentery. So ascending has no mesentery, transverse has mesentery, descending has no mesentery, sigmoid has mesentery. And then the sigmoid, this is how the colon looks from the inside. You can see the haustra here. That's how it looks from the inside. And you can see here that there are like 1, 2, and 3 places. Looks like triangular. So there are 3 places where the 3 teeny coli are located, giving this appearance. The liver is located, actually it's a very big organ. You will find that. It's the biggest visceral organ, not the biggest organ, but the visceral organ located inside the body, in the cavity, in the abdominal cavity. And it's wedge-shaped, mostly in the right hypochondrium, extends into the epigastrium, and also extends into the left hypochondrium. It has 2 lobes, right lobe and left lobe of the liver, and has a smooth surface here. It's called diaphragmatic surface because it's just under the diaphragm. And then another surface, which we cannot see from this view, is called the visceral surface. And you will find, like in the lung, it has like bumps and depressions because of its relation to the viscera of the abdomen. So it takes the shape of the viscera of the abdomen. And again, this is only in the embalmed cadaver. It is not in the fresh liver. Fresh liver is not like that. This is the visceral surface of the liver. So you can see, for example, here there is an impression of the kidney, and there is an impression of the stomach, an impression of the duodenum, and so on. You are not required to identify these impressions. But this is the visceral surface of the liver, and you can see that there is a place here where structures pass in and out. It's like the hilum. It's a hilum, but it's called porta hepatis. Porta like door, so it's the door to the liver. Porta hepatis, and there are many structures. You are required to identify the 3 large structures. You are required to identify the bile duct, hepatic artery, and the portal vein. So there's an artery, vein, and duct, bile duct. So the vein is called portal vein, and the artery is called the hepatic artery. And then you can imagine that there is an H-shaped pattern, and the porta hepatis is like the horizontal bar of the H. There's a vertical bar here, which is the interlobar fissure between the left lobe and the right lobes of the liver. And there's another vertical structure here, which is formed by the gallbladder and the inferior vena cava. This is important to notice here. Look at the inferior vena cava. It grooves the liver. You cannot separate it from the liver. And in addition to that, it receives hepatic veins from the liver. So when you want to remove the liver, there's no other way but to cut the inferior vena cava. So that's why in all the livers that you will find detached in the lab or in diagrams, you will find that there's a piece of inferior vena cava attached to it because it grooves the liver and cannot be separated from it. It receives veins from the liver. So now I mentioned two things. I mentioned that there are hepatic veins draining into the inferior vena cava, and there's another vein here. I called it portal vein, while the artery is a hepatic artery, which means that the liver has two circulations coming into it. There is a portal vein bringing most of the blood of the liver and carrying 75% of this blood, and this portal vein drains the GI tract. It drains the GI tract from the esophagus, from the distal end of the esophagus down to the upper part of the anal canal. So everything that's going to be absorbed from the gastrointestinal tract, therefore, is going to be delivered to start with to the liver before going to the systemic circulation. And this is called a portal circulation. A portal circulation, by definition, means that, or a portal vein, by definition, means that it is a vein between two sets of capillaries. Here we have a set of capillary in the guts, and then a vein is formed, and then this vein enters into the liver and will divide into another set of capillaries. So that's why this vein is a portal vein, okay, between two capillaries. And then from these capillaries, veins will be collected that are the hepatic veins, and they will go to the inferior vena cava, to the systemic circulation, not to the portal circulation. So most of the blood of the liver, 75%, comes from the portal circulation, 25% comes from the artery, and that's why one of the distinguishing features of the portal vein and the hepatic artery is that the hepatic artery, as you can see it here, is smaller than the portal vein, because the portal vein delivers more blood to the liver than the hepatic artery. And the hepatic artery, therefore, delivers the oxygenated blood to the liver, while the portal vein delivers the nutrient-rich blood to the liver that has just been absorbed from the gastrointestinal tract. And then this blood will divide these blood vessels will divide into the liver, and they will form the sinusoids, or the sinuses, hepatic sinuses, which are large distended capillaries. I hope that you probably study them in the histology. And then they will collect to form the hepatic veins. So hepatic veins, as you can see them here, they are collecting together, hepatic veins, and open into the inferior vena cava. So this is how the portal vein is formed. You can see the tributaries of the portal vein, starting from the distal end of the esophagus, stomach, including the pancreas, the spleen, all the small intestine, large intestine, down to the anal canal. All of these structures, they are ultimately drained into the portal vein. And the portal vein will divide inside the liver, and then the blood will be collected by hepatic veins to go to the circulation. The portal vein does not drain into the inferior vena cava. We have the inferior vena cava in the abdomen, but the inferior vena cava drains other structures. It drains, for example, it drains the kidney. There's no need for the venous blood coming from the kidney to go to the liver. It's not nutrient rich. It drains the suprarenal glands. It drains the walls of the abdomen. So it doesn't drain the gut. The gut is drained primarily by the portal circulation to carry the blood to the liver. Also, we have the gallbladder, which is a distended, pear-shaped, like cyst, is located on the visceral surface of the liver. And the gallbladder, unlike the urinary bladder, it not only stores the bile, but concentrates the bile. In the urinary bladder just stores the urine. It doesn't concentrate the urine. The urine is concentrated in the kidney. But here, this gallbladder, it stores and concentrates the bile. And the bile is drained by two hepatic ducts, forming a common hepatic duct, which is joined by a cystic duct from the gallbladder. You need to identify these structures, and then they form a bile duct or common bile duct. The bile duct joins the pancreatic duct, main pancreatic duct, and they are going to be distended. And this distension is called the ampulla. Ampulla is like a distended, is like a jar, Roman jar. So it's distended part. So it's called the ampulla of Vater, and opens at the major duodenal papilla in the second part of the duodenum, which is guarded by a sphincter of Oddi, thickening of circular muscle fibers. This is the pancreas. It's a gland, double gland, exocrine and endocrine. And you can see that it has a head. You can easily identify it within the C shape of the duodenum, and has an uncinate process, which looks like a hook. And then it has a narrow part, neck, body, and tail that reaches the spleen. You will be able to identify all these parts of the pancreas. And inside it, the exocrine part, exocrine means that the gland secretes into a duct and has local effects. Endocrine gland, the gland secretes into the blood, and so the hormones have far-reaching effects. So the pancreas, the endocrine parts of the pancreas, histologically speaking, you can only see that under the microscope, are the islets of Langerhans that produce the hormones like insulin, glucagon that control blood sugar. This is the endocrine part of the pancreas. You will not be able to see that. You cannot see them grossly, but you will see the exocrine part of the pancreas. You can see that it has a major pancreatic duct, which joins the bile duct and are distended as the ampulla of Vater. And there is another duct, small duct, not always present. It's called the accessory pancreatic duct. And this opens, when present, it opens into a papilla, small papilla. That's why this one's called major, because the other one's called minor duodenal papilla. So this is the exocrine part of the pancreas. This secretes enzymes, digestive enzymes. So that's why these enzymes, they have to go to the gastrointestinal tract by the duct in order to do the digestion here. And the bile as well will be important. The bile is an excretion, as well as it's important in the absorption of fats from the intestine as well. The spleen, you will be able to identify it. It's located in the left hypochondrium and related to lower ribs. That's why fractures of lower ribs might injure the spleen. It's so friable, easily injured, and once it's injured, it will result in severe intra-abdominal bleeding. That's why they usually remove it if it is injured, splenectomy. Again, it has a hilum, and it's part of the immune system of the body. Lymphocytes proliferate, bacteria are destroyed, red blood cells, because they have a lifespan, are destroyed there. And when it's removed, its function is taken by other organs in the body, like the liver, the bone marrow, lymph nodes, and so on. The spleen is intraperitoneal, and the spleen cannot be felt below the costal margin. If you are examining a patient, you cannot feel the spleen unless it's about 2 to 3 times its size. Then it can be felt below the costal margin. The kidney is retroperitoneal. You can see here the right kidney is lower than the left, and this is obvious because of the presence of the liver on the right side. It will push the kidney down, push the right dome of the diaphragm up. So that's why the right kidney is lower than the left, and it has a hilum, again, on its medial side that transmits the renal vein, renal artery, and a distended upper part of the ureter, which is called the renal pelvis. So these 3 structures are the main structures that you are required to identify at the hilum of the kidney. And then a section of the kidney, again, you are required to identify the features of this section of the kidney. It has a cortex, which contains glomeruli and renal tubules, and it has a medulla, which only contains tubules, and the medulla is very characteristic. You can easily identify it. It's pyramidal in shape. The apex of the pyramids are directed inwards, and they open. It's called they call it renal papilla. The multiple ducts open there, so it's always dribbling. They open into a cup, a small cup. This is a small cup here, which is called a minor calyx. And then 2 or 3 of these minor calyces, they form a larger cup, which is a major calyx. And then 2 or 3 of these major calyces, they open into this distended portion of the ureter, which is called the renal pelvis. And then it is going to continue as the narrow ureter. And the ureter continues down into the pelvis, where it opens into the urinary bladder. So this is a major calyx. It's formed of 1, 2, 3 minor calyces, and then 1, 2, 3 major calyces. They open into the renal pelvis. Here's the ureter. It's about 25 centimeter in length. There are many structures in the body that, actually 3 structures that are 25 centimeter in length. Is the duodenum, the esophagus, and the ureter. Suprarenal glands are located, as their name indicates, on top of the kidney. The other name is adrenal glands. And these are endocrine glands. They secrete hormones. They have a cortex and medulla. They secrete different types of hormones. The cortex secretes steroid hormones. The medulla secrete the catecholamines, the adrenaline and noradrenaline. And these are the branches of the abdominal aorta. So you are not required to identify these branches, but you are required to identify the unpaired visceral branches, the celiac, superior mesenteric, and inferior mesenteric artery. Only the main artery. You're not required to identify the branches of these arteries, and also the terminal branches. The aorta, as it reaches the 4th lumbar vertebra, it divides into common iliac arteries, right and left. This is the left, and this is the right. Common iliac artery. Whenever you hear the word common, it means that the artery is going to divide again. So common iliac is going to divide into an external iliac and internal iliac arteries. We're going to talk about that later on, like the common carotid, which divides into external carotid and internal carotid arteries. So one point about embryology that will be very helpful for you to understand the blood supply of the gastrointestinal tract is that, embryologically speaking, the gut tube is divided into 3 parts. It starts as one tube, but it continues to fold and increase in length, and is divided into 3 parts. The first part is called the foregut, the red one here, and then we have the midgut and the hindgut. So the foregut is from the esophagus, stomach, and part of the duodenum. It's the level of the major duodenal papilla. So half of the second part of the duodenum. Remember the major duodenal papilla, which receives the opening of the pancreatic duct and the bile duct? That's the border between foregut and midgut. So the midgut includes the distal half of the duodenum, all the remaining part of the small intestine, the cecum, the ascending colon, until it reaches the splenic flexure. That's the midgut. So it's not only restricted to small intestine, but the beginning of the large intestine until the splenic flexure. And from that point, it is the hindgut. To make things easier, the celiac trunk, remember these are the unpaired visceral branches of the abdominal aorta. You will find that the abdominal aorta is a little bit shifted to the left of the midline, and it is the continuation of the descending thoracic aorta. So the first branch here is called the celiac trunk. It supplies the foregut. So if you are asked, for example, what is the blood supply of the proximal half of the duodenum, you will recalculate proximal half of the duodenum is foregut, so it is celiac. Distal half of the duodenum is midgut, so it will be the next branch, superior mesenteric artery. And then we have the inferior mesenteric artery. So if you are asked, like, what is the blood supply of the sigmoid colon, immediately you will calculate that the sigmoid colon is part of the hindgut, so it is the inferior mesenteric artery. The inferior vena cava is the other large vessel you will be able to see in the abdomen. You have seen that the inferior vena cava in the thorax, you didn't see a length of the inferior vena cava, because once it passes through the central tendon of the diaphragm, it opens into the right atrium. But here you will find the length, the entire length of the inferior vena cava. It's a little bit to the right of the midline, and you can see here that it's formed by the union of two common iliac veins. So it receives venous blood from the kidneys, suprarenals, gonads, abdominal wall, but not from the gastrointestinal tract. So there's no vein draining into it, bringing the blood from the GI, because all this venous blood, goes to the portal circulation. It goes to the liver, and then from the liver, it opens into hepatic veins into the inferior vena cava. By the gonads, it drains the gonads. Yes, the gonads are the testis and the ovaries. So the ovaries are present in the pelvis. The testis is present in the scrotum outside the body, yet their venous blood, as well as their arterial blood, comes from the abdomen. Because originally speaking, embryologically speaking, the gonads develop in the abdomen and then they descend down. The testis continues the journey down to the scrotum, but the ovary stops at the pelvis. So while they are descending, they drag their blood supply and their nerve supply with them. That's why the blood supply comes from the abdomen and drains into the abdomen. And obviously, the veins do not require to drain into the portal circulation. They should drain into the systemic circulation.